So, good morning, good afternoon, good late night, depending on where you are in the world. Today, we're going to be talking about the oral systemic connection. There's a major connection between teeth and the heart and the brain. I'm going to give away a little bit of it, but the vast majority of it you'll have to stay to listen to. You know, there's always been some acknowledgement that heart attack and stroke are very much related to gum and tooth health. Why is that? Well, it turns out there's some direct connections, and we'll talk about a little of those today. Phil and Ari will do that, and I'll introduce them in just a minute. But there's also another connection that's critical. And in epidemiology, we used to talk about, causality. And the short version is this: does A cause B? Does B cause A? Or does C cause both of them? And one of the biggest challenges in this space is that prediabetes, diabetes cause both gum disease and heart attack and stroke disease, arterial disease. But it also turns out that gum disease in and of itself has been related, and there's been some demonstrations of causality for heart attack and stroke. There's a few ways of looking at it. One is that when they go, and they have found the same bacteria in the clots that they found in the gums, causing. So there's a big issue here. Now, I'm going to take a second and introduce Phil and Ari, then go ahead and talk a little bit about the rest of the show. Now, Phil and Ari Feldberg, I think we had a slide for you guys. Where is that? Hold on just a second and let me find that. There we go. Phil and Ari practice dentistry in Connecticut. Windsor, Connecticut. It's about an hour from Greenwich. I used to live about half an hour from Greenwich. Beautiful area. Are we losing me?
Yes.
Uh-oh. I tell you what, why don't we go straight into the Ari, why don't you go ahead and go straight into your section? I'm going to see if I can clean up my connection, and then we'll come back a little bit later.
Okay.
With my...
Sounds good. So my name's Ariana. I'm a registered vascular specialist, and I do the CIMT screenings with my dad. Dad is a dentist in Connecticut, and I'm going to let him start with the introduction of the oral cardiovascular connection.
So again, good morning, good afternoon, whatever time of day it is where you're listening. I think that the people that will be watching us today fall into three groups. One is a group of people that not only is aware of the connection between gum disease and abscessed teeth and heart and stroke issues, and are doing something about it. Second group has heard about it, but they haven't quite reached the decision to, gee, I really need to take control of this. And the third group of you may not even be aware of that. So, Ari, this is the second slide, correct?
Yep.
Okay, so I'm going to start with kind of a sad story. I had a 23-year-old grandson who had a pre-existing heart condition, and he had some abscessed wisdom teeth. The infection entered his bloodstream and attacked his weakened heart. And by the time his girlfriend parked the car at the emergency room and came back in, he was already intubated, and 3 days later, he died. Now, I didn't tell you that story to panic you or get you upset, but I think it's really important that this is why, Ari and I and Dr. Brewer are excited to present to you some more information and knowledge about what we're going to do. So I'm going to let Ari go on to slide number 3. We'll talk about a bunch of stuff. Go for it, Ari.
So when it comes to the story with my nephew, at 23, you're indestructible, and you think, it's just an abscess tooth, it's no big deal, it's whatever, it has nothing to do with my overall health. But the surprising part is a third of the people that actually have a plaque removed, when they take that plaque out for carotid artery surgery and they analyze it, a third of those people have dental DNA in there. So that statistic to me is kind of shocking. First of all, it's super rare to even qualify to be able to have the surgery. You have to be more than 70% occluded to even qualify to be a surgical candidate. But assuming that you do qualify for that, and they take that plaque out and they analyze it, a third of those people have dental DNA in there. So that means a third of those people that were about to have a heart attack or stroke that actually qualified, they had such a big blockage that they needed to have surgery. That inflammation or that infection started in your mouth. Blech. So whenever I scan people, I always tell them, it's more than just a pretty smile. It's not just a little pink in the sink when you brush your teeth. It can be, not always, but can be indicative of a much larger health concern. So definitely taking good care of your teeth and gums is super important. And it's something that we can all do. You brush your teeth, you floss your teeth, you go see your dentist. It's not rocket science. It's not anything that's difficult to do. And it's something that we all have well within our purview.
This is interesting. I'm going to hop back in because a number of years ago, when I went to a nursery school in Windsor, one of the little girls, I was talking about good foods and fun foods, and we talked about plaque. And this beautiful little 4-year-old girl said, Dr. Feldberg, it's not plaque, it's Goop. So from this point forward, I've been calling it Goop. And I just want to share with you, I'll get my elbow up here, my wrist up here, around your teeth attached directly to your gums, but not at the top. There's a little ditch like around my cuff that the bacteria can hide out in. And this is why you need to floss and get a toothbrush bristle into that to disrupt 75 to 80% of that goop. And when you do that, what's left is there's a bacteria in Greenwich, there's a bacteria in Windsor, there's a bacteria on Martha's Vineyard. They're so far apart that they cannot organize to begin to burp out acid and create inflammation that allows these bacteria to migrate directly through your skin into your blood system. And this is why, people are not even realizing that you need to change habits. But in the 1850s, Dr. G.V. Black, the father of modern dentistry in this country, in his treatises write about the value of passing a thread between the teeth to avoid the ravages of dental disease. This is in the 1850s. Excuse me, 175 years later, a whole bunch of people still are not flossing. And while it's not always easy to change that habit, when you have a pretty healthy mouth, it shouldn't take you more than 45 seconds to a little over a minute to get in between those teeth with floss and remove that goop. You're on, Aaron.
So oral plaque versus cardiovascular plaque. I get asked this all the time when I scan people. They're like, well, is it the same thing? No. Same name, different plaque. So, and here's how it works. We've already talked about the oral plaque and how that works. So let's talk about cardiovascular plaque. And basically all I want everybody to kind of remember and stick in the back of your mind that all plaque is a large inflammation. Once it reaches 1.3 millimeters, it actually qualifies as a plaque. So the more inflammation you can remove systemically, the better off you are. Because again, all that a plaque is a large inflammation. And so what causes inflammation? A lot. There's a lot of things that cause inflammation. It can be caused from stress. It can be caused from lack of sleep, poor diet, nutrition, any kind of chronic itis. So rheumatoid arthritis, ulcerative colitis, diabetes, which works a little bit differently, but it's the same idea. And I'm sure Dr. Brewer can explain this way better than I can. But the way it was explained to me when I was at school is that when you're diabetic and you have all this extra sugar that's kind of running around in your bloodstream, it works like little knives and it makes little slits and cuts in the lining of the wall of your artery. And when those nicks, cuts, and slices and tears happen, stuff gets stuck in the wall. Especially small cell cholesterol loves to get stuck in there. and again, I'm sure Dr. Brewer can get to the more technical part, but let's just say stuff gets stuck in the wall. And the more stuff that gets stuck in the wall, the more inflammation you get. And eventually that inflammation is going to become a plaque. And so, the more things that you can do to reduce that, keeping your diabetes under control, keeping your sugars under control, preventing diabetes from even happening would be better. But any kind of chronic itis that causes systemic inflammation is going to eventually affect your cardiovascular health as well as your oral health. And so what else causes inflammation? Well, dental disease. That's why we're here. So one of the major things to make sure that you keep in mind is, unlike my nephew who was 23 and thought he was indestructible, don't ignore problems in your mouth. Go see your dentist. Make sure they're looked after, because they may be the tip of the iceberg of things that are a much bigger concern.
I just want to hop in with one other comment about that, and that is, even if you go see your dentist or your hygienist once a month, there's still 353 days, 354 in leap years, that if you don't remove that plaque, it's busy irritating and causing inflammation. And what happens is, as Ari said, that single cell lining weakens and it allows the inflammation. And the other reverse happen is, once that plaque is in there, which Dr. Brewer is going to talk about, it gets, what's the nature of it? And if it ruptures, your body does some amazing warfare, builds stuff around it, creates a clot, and that's what kills you.
So let's back up a half a step. Dad kind of jumped ahead a little bit there. So one of the things that, I became so passionate about is doing CIMT scans. This scan literally saved my life. This is career number 3 for me. And had I not gone back to school to learn how to do this, I would have been a statistic. I would have been one of those people that just randomly dropped dead for no apparent reason by the time I was 50. I grew up a vegetarian. I grew up an athlete. I always did what I was supposed to do. I didn't do what I wasn't supposed to do. I have great blood pressure. I have low cholesterol. I have, no family history, which is super rare in today's day and age. But yet when I was back at school learning how to do this, and we were practicing on each other, the woman that was practicing on me, all of a sudden in this horrible, timid voice went, Todd? And nobody wants to hear Todd said with that kind of trepidation when you're the guinea pig on the table and Todd's the instructor. So sure enough, they found one of the really dangerous soft squishy plaques in my right carotid artery. And nobody really understood where it came from. And had I not gone back to school to learn how to do this, I would have been one of those people that just randomly dropped dead. I didn't have any of the precursors. I don't have any warning symptoms, no flags, none of that. So I became super passionate about scanning as many people as possible. And because you really just don't know what's lurking beneath the surface until you take a good look. And so that's why I do CIMT scans. I think they're amazing. I'm sure Dr. Brewer has spoken of these multiple times before. And so I'm just going to kind of touch base really quickly about what a CIMT is, and what a scan is, and why should you consider having one. What a CIMT is it stands for carotid intima media thickness, and it measures the innermost layer of the wall of the carotid artery. And it detects atherosclerotic plaque, which is responsible for most heart attacks and strokes, as well as the CIMT also measures inflammation, which is the precursor to plaque. Because if you remember my earlier babbling, all plaque is a large inflammation. So if you can start measuring the inflammation of your carotid arteries, and it actually has a 95% correlation rate to what's actually going on in your heart and in your brain. And the CIMT scan that I have, that I've been certified through Dr. Todd Eldridge with CardioRisk, they have proved that the efficacy is 98.6% in predicting heart attack and stroke risk prior to them happening. And I'm one of those people. It saved my life for sure. So looking at this slide here, you can see what a normal artery looks like. And when you're born, that lining of the wall is nice and tight, and it's like a Teflon conduit, and everything just kind of slides right through with no problems. And then life happens, and we get nicks, cuts, and tears in the lining of the wall. We get stressed out. We don't sleep well. We're exposed to toxins environmentally. We eat things that we shouldn't eat. All sorts of things cause problems in that lining of the wall. And eventually you do get nicks, cuts, and tears. And the more nicks, cuts, and tears you get, the more stuff gets stuck. And the more stuff that gets stuck, the more inflammation it causes. And the more inflammation that there is, the more stuff gets stuck. And you sort of get where I'm going. It sort of snowballs until eventually you have this big old inflammation that probably is going to qualify as a plaque. And the thing that's most important to remember about a plaque is Size doesn't really necessarily matter. What's way more important when it comes to plaque is the stability. What kind of plaque is it? Is it soft and squishy? Is it kind of in between? Or is it hard and calcified and more like a cyst? So if you take the analogy, it's kind of gross, but you'll understand in a second. If you think of it like a pimple on your face, the most dangerous equivalent to a teenager having a whitehead pimple that's ready to rupture at any moment. Because most often what causes a heart attack, a stroke, is when that plaque ruptures. And what happens is the way that it was best explained to me, and I'm sure that there's way more technical ways to explain it, and Dr. Brewer, jump in if this is wrong, but the way it was explained to me is it kind of, your body has the same reaction that it does when you cut your skin. Your body goes, oh my gosh, I'm bleeding, and it wants to stop the blood flow, which is great when it's on your skin because we don't want you bleeding to death. We want to keep the blood in your body. The challenge is when you have a plaque rupture in the wall of the lining of your artery, your body has that same, oh my gosh, I'm bleeding response. And the same sort of reaction happens and your body wants to stop the blood flow. The challenge is it does a little too good of a job when it comes to your arteries and it causes a blockage. Before I started going back to school to be a CIMT technician, I always thought the heart attacks and strokes were caused solely from a blockage. And they are, but if you take it the quarter of a step back to figure out, well, what caused that blockage to begin with? Most often it's not because their arteries were gummed up and it just kind of slowly over time squished off the blood flow and that caused a heart attack or stroke. Most often what actually causes a heart attack or stroke is when that plaque ruptures and it's your body's, oh my gosh, reaction to I'm bleeding and I have to stop the blood flow. Same kind of idea as when you cut your skin. So that's why CIMT is so important. It will pick up the first indicator of atherosclerotic disease, which is inflammation. And then it'll also detect if you have plaque, it'll qualify what kind of plaque it is. And that's a big, huge take home message that I want you guys to remember is when it comes to plaque, the stability is the most important thing, not the size. Is it soft? Is it in between? Or is it hard? So please, 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 if that's the only thing you remember from this whole thing of me babbling, remember that when it comes to plaque, stability is the most important thing. Okay. So a couple other facts about CIMT. Cardiovascular disease is the #1 killer for both men and women. CIMTs can catch 98.6% of heart attacks and strokes before they happen. This was done in a 10-year, 10,000 person longitudinal study. It's called the Cafe Cave study in case anybody wants to go read about it. Something that would definitely never get approved today. But thankfully, these folks agreed that regardless of their findings, they would not seek treatment. So if regardless of what their CIMT showed, they would not go seek medical intervention. So they would kind of let things happen as they did. And that's what proved the efficacy of CIMT to be 98.6% effective. It's painless. It's non-invasive. There's no needles. There's no disrobing. There's no radiation. I read an interesting study published not too long ago that they're actually using CIMT for newborns for women who had gestational diabetes. And they were trying to see if that gestational diabetes had any kind of effect on newborns with their inflammation or their CIMT, which I thought was kind of cool. So if it's safe enough for a newborn to do, it's safe enough for anybody to do. It takes about 20 minutes. It's an easy test. You get to kind of come hang out and lay down and I do all the work or the technician that you go see does all the work. And the really important thing too is most patients that have the early or intermediate stages of cardiovascular disease have no outward symptoms. So it's not like you wake up in the morning and you're like, oh, I got to call in sick today because I feel a stroke coming on. It doesn't work that way. Unfortunately, there's absolutely no warning. 50% of men and 64% of women who die suddenly from coronary artery disease have no prior symptoms. And oftentimes they don't even know that they're having a heart attack or a stroke. So here's a couple other CIMT statistics. One person dies every 34 seconds from cardiovascular disease. I was recently invited to participate with Doctors Bale and Deneen at a pretty cool event at Mohegan Sun. And Dr. Bale described things in a really unique way. He said, if you're ever out in public and you look around, notice when somebody touches their face and how often people touch their face. Now, granted, because of COVID, we have all been trained to pretty much sit on our hands and don't touch your face anymore, but people still do it. I'm sure I've done it during this presentation. If you're out in a mall or you're walking through the airport or you're in a boardroom, just kind of take a second to look back and look around the room and see how often someone touches their face. Every time someone touches their face, someone has a heart attack. Now, no, they're not causing someone to have a heart attack. It's just showing the amount of time that passes, that every time someone touches their face, someone is having a heart attack or a stroke. And it's pretty shocking how often people touch their face. About 857,000 people died in 2020 from heart attacks and strokes, and 1 in every 4 deaths and 1 in every 5 deaths from coronary artery disease are less than 65 years old. So 1 in every 4 deaths is caused by coronary artery disease, heart attacks or strokes, and 1 in 5 are under 65. That to me is shocking. Like, I thought we were all getting healthier, but we're not. We're doing the same thing. It's the definition of insanity. We're keeping the same things of going for primary health and, doing everything that we think we're supposed to be doing. And we're expecting different results. And that right in and of itself is the definition of insanity. You can't do the same thing over and over and wonder why things aren't changing. So 20% of people who have a heart attack or stroke, like Ed mentioned, don't even realize they're experiencing a heart attack or stroke. And our goal is to have you live as long as you can, as healthy as you can. In the little picture here that we drew, it's a horrible picture, but you'll get the point. The one on the left is a healthy cell wall with the single cell lining. They're all touching each other. That would be like when you're born, and everything slides through like a nice Teflon conduit. And then the one on the right is when life happens. You start becoming unhealthy. You get some nicks, cuts, and tears in the lining of that wall, and those single cell linings are no longer touching each other. So stuff gets stuck. LDL cholesterol, blood clots can get in there. Dental DNA, like we talked about, that's why we're here. All of that gets stuck in the wall and causes problems, and causes inflammation. And then again, inflammation causes plaque. So that's kind of our spiel through here. Hopefully Dr. Brewer has gotten his connections certified back together again. And I'm sure he can fill in much more of the gaps than I can. But
and I just want to hop in and come to the close of this part of the presentation today to say we need your help. The most important member of your healthcare team is you. And as when mammograms first came out, docs and insurance companies and hospitals didn't say, oh, let's get women mammograms. Women said, this is a very important test that even with 3D imaging now, they still miss up to 20% of breast cancers. This simple gateway test of a CIMT scan of your neck is something that when enough of you, and we're finding this in the groups that we've been working with, municipalities and people with wellness budgets and people with HSA stuff, but we really need to reach out to get somebody to step up the plate to say, okay, we're going to pay for this. And that's one of the things that we may talk a little bit about this morning. So for me, for those of you, I don't care which group you're in, group 1 that is taking care of it, group 2 that not quite ready to make the decision, or group C that doesn't have a clue about this stuff, carefully listens and maybe rewatches this and reaches out to get some help, because not all physicians, and Dr. Brewer will talk about this, are going to buy into having you do this. But the technology has made enough progress that we can have your health expectancy equal your life expectancy. And I'm done.
So thank you, guys. Ari, let me just give a caveat on the connection here. I've used this. I'm in a different location today. I'm in Athens, Georgia. And I've used this studio Wi-Fi about 5 times so far, I think, maybe 4. Never had a problem. It always worked like a charm until we go on the air. So I've obviously been distracted. Aspen and I have been working in the background trying to evaluate it. Hopefully we'll survive the show anyway and be able to at least get some good information out there. I appreciate what you've shown. And I will go back and say, yes, one of the things Dr. Feldberg and I wanted to talk about was how to make this test available. It has been a struggle. Phil, why don't you share what you shared with me? You don't have to use names to protect the innocent if you don't want to, but I think this discussion is helpful for others who have an interest in this channel and in heart attack and stroke prevention. Who we've got about 100 people watching right now. There will be about 1,000 over the next day or so, who have an interest and who know that stress tests, the standard stuff, is just a flow study. And even your typical ultrasound of the carotid is just a flow study. The CIMT that Ari's been talking about, that Ari's been trained in, that Ari used to discover her own plaque, which she described, is something a little bit different. And unfortunately, I'm not aware yet of any insurance company that covers it. We'll talk about let me go ahead and frame this up for a second and talk about why, and then you can talk about what you shared with me.
Sure.
So I've had Todd on the channel. For those of you who want to go deeper into some of the technical challenges that I'm going to describe next, you can go to those. We've got about 5 hours worth of technical detail in it. There are a lot of different things to look at in this space. First of all, let me talk about the difference between a flow study and what we're talking about. You would assume that what we want to know is the blood flowing well in the artery? If that's good, the assumption is there's no risk for heart attack and stroke. Unfortunately, that assumption is flat wrong. You go to groups like Princeton Prevention Unit, and they have demonstrated 2/3 of heart attacks and strokes occur in people whose blood flow, the flow in their carotid arteries, the flow in their cardiac arteries, all of that blood flow is just fine. 2/3 of the people having heart attacks. So if you wait until you have a problem with the flow in the blood, you're going to miss 2/3 of the people that are going to have a heart attack. That's not a good screening process. So that was acknowledged. That's what led to this. There's got to be something else. There's got to be something else. Ari mentioned the Cafe de Cave study. That was about what? Was it 10,000 people, Ari?
Yep, 10,000 people over 10 years, so 100,000 people total.
100,000 person years.
Yep.
And it was done in Italy, I think. Really good study group. Ari referred to a couple of things about, they said, well, look, we're not going to treat them. And that was the standard of care at the time. They were using a CIMT. It was a totally experimental type of process. And what they found was, oh my goodness, if we see plaque on these people have a significant, huge increase in risk of having heart attack over the next 10 years. Now, here's the question. How do you see plaque? And what's the difference between CIMT and ultrasound, the ultrasound of the neck? It looks like the same thing. It's the same, what we call interrogation, well, not exactly the same interrogation, but the same technology up to a point. And here's where it's different. This is not CIMT is not looking at the flow of the blood in the artery. It's looking at the thickness of the artery wall in a very specific place. The place between the IMT, intima media area. So plaque is really, it's LDL plus often some inflammatory liquids and tissues that have been deposited. They have gone through the intima layer of the artery, and they got stuck. Now, Bobby Ocampo has a question a little bit later we'll discuss it in the Q&A section about microalbumin creatinine ratio. That's actually, when you have a positive microalbumin creatinine ratio, this is what's going on. You're having a leakage of that intima layer. If you're having a leakage of that intima layer down in the kidneys, the filters of the kidneys, then you're also having a leakage in the arteries of your heart and your neck and your brain and everywhere else, because that lining is the filter membrane of each of the million filters in the kidney. Now, I hit you with a bunch of stuff real fast. Let me go back and maybe clarify it. The kidneys have a million filters in each kidney. They're called glomeruli. A filter is simply a structure with a filter membrane. And that's what's going on. The kidneys start with a filter membrane. That filter membrane is simply the lining of the artery wall. So the media layer retracts back, and in each of those million filters, glomeruli, in each kidney, you've got an area where it's nothing but the lining of the artery wall. Now, if protein is leaking through that lining, that intima layer, we also know that LDL, small dense LDL, can leak through as well. It won't leak through the media layer, it gets stuck. So if we start measuring the difference, the gap between the intima layer and the media layer of the artery wall, that tells us if we have plaque. That tells us if we have inflammation of the intima. So that's the difference between a flow study and a CIMT. A flow study is just looking to see, is there flow in that artery wall? A CIMT, on the other hand, is going back. It's using some analytic technology it'll take a centimeter of flat artery wall, common carotid artery, and it'll look very specifically. It takes 600 cuts in that centimeter. It analyzes the distance between the intima and the media layer of that artery. And that then starts to tell us how much inflammation we've had, how much leakage we've had of the LDL through that lining and into the intima media layer. Any comments? I realize I got fairly deep fairly quickly. Phil and Ari, any comments to help maybe clarify what I'm talking about?
Again, when people hear some of that scientific stuff, but they need to know that stuff. Dr. Brewer and I have those letters after our name. And when I was 13 years old, I got a Webster's New Collegiate Dictionary, and I'm kind of a dictionary nerd. And I looked up, what is the meaning of doctor? And the archaic meaning of doctor is teacher. So one of the most important things that we do is not fix stuff or diagnostic stuff. It's to educate you to know what's going on. And I think that Dr. Brewer has co-authored a book with Dr. Eldridge, The Prevention Myth. There's a lot of stuff that, while maybe very scientific, we've been trying to get it out in terms that you can understand. So Dr. Brewer and I and we got in touch of one of the major nationwide carriers a couple of years ago and had this conversation with one of their medical directors. And one of the main areas of focus that we have at this point in time is we want somebody to step up to the plate, because one of the things Ari did in the middle of the pandemic was go to some municipalities in Eastern Connecticut and scan over 350 people during the height of the pandemic. She had lots of masks, let me tell you. And the data that came out of that, because I'm going to be a little technical about the way if you have insurance coverage, it's either through the group is self-funded. That means your money and the employer's money gets put in a pot, and they have to buy stop loss insurance, which says if they have to pay out too much for a heart attack, which can cost between 80 to 125,000, and sometimes more. Like if you live on Martha's Vineyard where Ari is, and you got to get airlifted to Mass General. And what they found was in this group, 85% of the people had some kind of dangerous markings that are predictive of what's going to happen. And 60 some odd percent of those people were in the red. Now, the thing that Dr. Brewer's talked about, and we actually have talked to Cardio Risk about this, when you get this report, we really want them to emphasize, not just do you have plaque, is it soft, mixed, or hard? So we have been expending a significant amount of effort with a couple of different positions to get in front of these carriers nationwide. And there are two. One in particular is willing to revisit their medical director. Northeast Regional Medical Director has changed. They have a new one who is open to this. And Dr. Brewer has mentioned that he'd be willing, if we can get in front of these people, of a decision maker, because in lots of cases, he's been attempting to get this covered for a long time. And as some of you may know, as past director of medical director of Toyota USA, it's not your little local drugstore around the corner, is responsible, and he's had lots of opportunities to get in front of some really powerful people. And sometimes it just takes enough. But in this one group of 350, they had not a large number, but over that 1 year period, they had, I think it was 5 people that had a cardiovascular event.
Three.
And these three people cost what, over $1.5 million?
$1.6 million.
And in that situation, that's a heck of a lot of CIMT scans, because the scan is not outrageously expensive. But the idea is we really feel that we need your help, because I tell the story about mammograms multiple times. When they first came out, it was a groundswell of people that said, hey, we really need this. And they finally made some progress. So we're willing to keep putting forth effort, but we need you to get scanned. There are ways to do that. It's not available every place yet, but if you demand it, it will be. We only use Cardio Risk at all because they have the technology that's the gold standard. And then when you go to your physician, be aware that they're not going to run right in and say, oh, wow. They're not going to do that because they still are not aware. But we want to make them aware. And as Ari says, you be your best advocate. If your primary care doc says, oh, this is no big deal, I know in our case, we have some cardiologists that are very well tuned into it. And one in particular, I'll give you his name, is Aaron Agarwal, is a managing partner of one of the big groups in the Hartford area. And he said, I'd rather see you before the hospitalization than after. And for years, medicine has not been driven by prevention, but you can change that. So that's my pitch, and we're going to keep working at that.
One thing, too, that I just want to interject to real fast is, going back to what Dr. Brewer was talking about, the difference between a CIMT and a flow study. And it's hard for you as a patient to know the difference because it literally is the same procedure. It's the same transducer. We're rubbing gel on the same part of your neck. And you as a patient would have no idea the difference between what I'm looking at versus what a flow study is looking at. Because why would you? You're not the technician. Literally, the only difference is what the technician is looking at. And you as a patient would not know the difference. So oftentimes I have patients, plunk down in my chair and they're like, oh, I've had this done before. And I was like, I'm going to guess you had a Doppler done. I'm going to guess you had a flow study done because very few people have actually been exposed to a CIMT. I'm working very hard to change that. I would like to get as many people exposed to it as possible. But you have to be, and that's why I'm really glad Dr. Brewer brought this up. You have to be educated for the difference. There is a marked difference between what we're looking at. One has 98.6% accuracy of predicting heart attacks and strokes prior to them happening. The other, which is the Doppler in the flow study, misses 85% of the people that are going to have a heart attack or a stroke. So basically, we're sort of damning 85% of the population to go ahead and have your heart attack or stroke. And if you survive, then we'll help you. I don't think that's okay, which is why I'm so passionate about the IMT. And so don't be afraid to be your own advocate. Don't be afraid to ask questions. Your body, your health. If you have to be a bit of a brat in order to get an answer, then be a bit of a brat. I've had a lot of patients be like, well, my doctor said, and, doctors know all. And doctors do know a lot, but they can't possibly keep up with all of the new research and all of the new things because, let's face it, the way that insurance regulations are right now, doctors have to see a lot of patients in order to make ends meet, and they don't have the time to go back and read things at the end of the day. They're too busy seeing their patients. So my take-home message to people is, if it's your body and your health and you have questions, you deserve to have those questions answered. And don't be afraid to be a bit of a brat. Don't be afraid to really demand those answers. And if your PCP can't provide them for you, then find someone that can. It's super important. We want to keep you healthy. We want to keep you around. I will tell you a quick story of why I'm so passionate about saying that. I did scan a very dear friend of mine. I will leave my names out, obviously. He had some findings on his IMT. He had some pre-existing conditions. He is diabetic. And he had some family history of heart attacks and strokes. He's also in an ethnic group that has an increased rate of heart attacks and strokes. So when I scanned him and he had some questions, now I don't see people's reports, none of my business. I'm just the technician. But if they have questions, I'm always happy to be here as a resource and help answer, what the report is saying. So he brought his report over to me and he said, can you, kind of explain this to me? I don't really understand what it means. So I just went over, briefly with him and I said, you really need to talk to your PCP because there are some significant findings on this. And he took it to his PCP. His PCP, said, what? I don't really know what this is. I have no idea what it is. Like, your blood work all looks fine. We're just going to stick it in your chart and we're going to watch you. 3 weeks later, he had a massive stroke. Now that's infuriating to me. Like, the evidence was right there on the piece of paper, but because his doctor wasn't aware of what the test meant and just stuck it in his chart, he had a stroke. So when I say don't be afraid to be your own advocate, that's what I mean. If you have questions and you deserve to have answers, if your PCP doesn't know what they mean, then find someone that does. Because if you have that, information in your hot little hand, that's your ticket to health. So don't be afraid to demand answers. Okay, that's my soapbox.
Okay, so let me go back and go up to about 30,000 feet, maybe 60,000 feet. You hear us talking a lot about this screening process, CIMT, and you've heard us talk multiple times about the typical way of getting plaque evaluation. And that is the doctor's own version of doing a risk evaluation. Then the doctor's next statement of, well, let's get a stress test. Let's get a cholesterol test. Those are not great ways. And mostly what they do, once you start saying, okay, well, I will go ahead and get a stress test, usually the next place to go is the cath lab. And then once you get into the cath lab, if you have plaque at all, there's a very high probability that you're going to end up with a stent. Let me first give a couple of basics. This is not a simple area. I've spent a lot of time developing a couple of courses. There's a plaque evaluation course. I've got some free plaque evaluation videos. If you want to get a little bit deeper into understanding what you should do yourself, just search that on our YouTube channel, Plaque Evaluation. Let me give you some basics though. We've talked about ways not to do it. Let me talk for a second about the ways to do it. There are 3 techniques that we do recommend. As I said, I don't recommend a stress test. I don't recommend going to the cath lab. Here's what I do recommend. CIMT, as we talked about today, calcium score, which we haven't talked about today, but we've got plenty of videos on, and CT angiogram. CT angiogram is an up-and-comer. Got plenty of videos, free videos on that. Calcium score is good. It's got its challenges. One of the biggest challenges is it does not show whether you have soft plaque or not. CIMT is the only technology which shows that you have soft plaque or not. Now, it's very unfortunate that there's this continued debate about use of CIMT for screening. And here's where the problem occurs. Phil went into some detail on some of the challenges where he's making that, he's going into that area and having that, that debate. He's meeting with insurance professionals. As he said, I've spent years fighting that battle. And yes, I will be a sucker for getting involved in it again if Phil gets the right scenario set up. The concern is a concern about garbage in, garbage out. It's a valid concern. Now, and it's based on, like so many things in life, the incorrect assumptions. If you look at the science associated with CIMT, it's full of garbage. And that's frustrating because what it does is it messes up the rest of the picture. So people looking through the science in that area see tons and tons of studies that have been done by people who don't know, number one, don't know how to do quality control on the interrogation, which is a critical process. Number two, do not understand the variability. Number three, don't understand what the critical pieces are. Arterial age is the thing that's most easily understood. Arterial age is the place that has the most problem. Now, let's clear all of that out and say, well, Ford, given what you're telling us, why are you a big fan of CIMT? Because the one area that's most critical that you can get from a CIMT and you cannot get from anything else is really hard to screw up. It doesn't have any of that variability problems. It does not have any of the garbage in, garbage out. If you look at the science where there is garbage, and there's plenty of it in the CIMT area, it's not around this piece. And this piece is the plaque calcified or not? And if you just focus on that piece, this is a fantastic test. Yes, I agree with using it for screening. Yes, I agree with using it for using arterial age. But the problem is that variability issue has created so much confusion. We've thrown the baby out with the bathwater. And I don't expect you guys to agree with me 100% on that issue, but that is the way I see this. Any comments? Doesn't sound like there are. Okay. Ari and Phil, any other comments before we get into the Q&A section of the video?
I think we covered with the tone of what we want. We've made our asks. Now it's just to, have we educated not just the people on today, but you're well over 100 and some odd thousand followers, so that they become aware of being educated as, the benefits, in spite of whether they feel like they're swimming upstream. Because, if they are willing to take some ownership of that and take action, I think that we can really begin to see some real progress here. I think progress has been made, but it's like when you boil water. It takes 99% of the energy to get the first 1% boiling, and much less to get the other amount boiling. So, we need the support from as many different directions. And I think the more of this that you, Dr. Brewer, are willing to get out, it impacts more people. And sometimes they got to hear it 5 or 10 or 20 times. You don't stop saying it.
The other last thing that I just want to interject to is the great thing about CIMT is you don't need a doctor's prescription to do it. If you want to have this test done, you don't have to get permission from your physician. You can just go get it done. And I think that's huge, because it gives you a huge or substantial amount of self-control over your own wellness, and it's your body and your health. So it's nice to not have to, coerce your physician into giving you a referral. If you want this done, you just go get it done. It's easy.
Exactly. You don't need one for a calcium score. You don't need one for this. You do need one for a CT angiogram. And the reality is, I think it's a deeper level screening because you're injecting dye and taking CT tests. With the calcium score and the CIMT, they're both relatively harmless. As you know, Ari, there's no radiation associated with CIMT, but the radiation associated with the calcium score these days is so minimal, it's not a practical consideration for the risks that we're dealing with. I look forward to the day to where we have an area on every corner, just like we have an X-ray imaging section on every corner, so people can go in and get a calcium score and get a CIMT. Any other comments before we go into the Q&A section? Very good. Well, I tell you what, if you'll give us the transition, we'll go into Q&A. So we've had a couple of donations on the super chats. One was tired of looking for name, $20. Thank you so much. Tired of looking for name, and great topic as pretty much always. And then there was another one, which I will show in just a minute. I think it was William Brewster who gave us $10. These, if you look in the upper right-hand corner of your screen, you see how to do a super chat. You go down to the bottom of the chat section, click super chat, and it'll tell you what to do from there. That may sound like not such a big deal compared to the dollars associated with the staff to run this program, the technology, and sometimes, maybe it will help me afford a better Wi-Fi connection for today. But no, it does help because we've got folks, Aspen, for example, Rafi, are both in the Philippines, helping us in the background manage and do the transitions. Aspen was helping me with my connection while Ari was giving you some presentations. So it takes money to run this, and people are benefiting from it all over the world. Including Asia. China, for example, is my number 5 country in terms of uploads for our podcasts. So let's go into some of the questions. Bobby Ocampo, also in the Philippines, Mabuhay, which means, it doesn't mean like and share. It means something like happy life, good life. So thank you again, Bobby. Bobby must be some sort of healthcare professional because he does understand a lot of what we're talking about. And I think he might actually be a doctor in the Philippines. One of his questions is MRI for the brain important in predicting possible stroke? Does microalbumin creatinine ratio relate to the capillaries in the brain? Any research on prolonged fasting and prevention of stroke? So let me just deal with a couple of these out front. Does elevated MACR, microalbumin creatinine ratio, have any relation to capillaries in the brain? Does it show potential stroke? And is there research on fasting and prevention of stroke? Fasting as well as microalbumin creatinine have both been researched in terms of association with cardiovascular events in general. And yes, increased microproteinuria has been shown to have significant association with cardiovascular events. Not strokes in particular, as opposed to other types of cardiovascular events. And I spent some time and put that in writing for you, Bobby, as well as others who are interested in this. There's actually only one risk factor that I'm aware of that shows some particular risk associated with stroke beyond the other cardiovascular events. And that's high blood pressure. High blood pressure does have significant, let me correct myself. There's 2 of them. One is high blood pressure. The other one is atrial fib. And I have both of those. I should have remembered that. The other major risk factors that we talk about again, are overall for cardiovascular events, not just stroke alone. These are not for just stroke alone, but they do have some special risk associated with stroke. Phil, Ari, any comments on that one?
That's not in my lane.
Yeah. Awesome. Dennis Williams says, awesome questions. He also says the Feldbergs are talking about the oral cardiovascular connection. Thank you so much, Phil and Ari, for sharing that with us today. And thank you for the work that you're doing. Again, it's so nice to have folks that are out in the dental community recognizing that, you know what, teeth are important, but guess what? Hearts and brains are important as well. And dentists actually have a huge role to play to help us in terms of understanding our risk, understanding the gum disease that we have there, and helping us understand what we need to be looking at to protect not just our teeth and the way we look, the way all of the things that are associated with the mouth, but also our heart and our brain. This is a much bigger issue than most dentists take on. So Dennis Williams says he's enjoyed the book James Nestor called Breath. I read that book. Portions deal with this very subject. They do. It's a good book. I enjoyed it as well. I will give the caveat that there was a little bit of a stretch on some of the science. Some of the science was a little bit soft, but overall, still a very interesting book. And here's another component to it. Breathing is very, very important. And it's also very, very neglected. Phil and Ari, there's a significant number of dental units, dental offices that are starting to get deeper into breathing. You both are, I'm sure you're aware of it because it also involves cardiovascular risk. Are you involved with that at all at your operation?
It's interesting you say that because Ari a while ago went and got trained and certified to do these EMA appliances. And
For
for
sleep
years,
apnea. For sleep apnea, for patients
Sleep
that can't
apnea.
tolerate CPAP.
For years, CPAP machines have been the gold standard. The problem is up to 40% of the people don't use them. So this company in Buffalo, New York, came up with a design that is a simple appliance that actually has these rubber bands that takes and pulls your lower jaw down and opens your airway. And what they found is finally the sleep apnea people, although it's not widely used yet, but I've had a good number of patients that we fabricated these are. And in addition to their significant other spouses that say, I can finally sleep, the patients themselves are greatly appreciated. And it happens in younger people also. So there are some, again, you have to have the healthcare providers and hygienists are involved in this too. There are some simple questionnaires that can help find this. But this particular appliance, although not widely all over the place yet, has been accepted as an alternative because you get more compliance. You get people to wear them because they don't snore and they sleep better. And that's a really important element.
I used an appliance for a couple of years and got some improvement there. One of the interesting things that happened to me, perhaps the biggest component, well, maybe a couple of different components. Number one, I discovered that I had the problem. I never knew that I had it. And that is one of the bigger issues. Number two, I had Invisalign. And what happened with the Invisalign was it actually expanded my lower and upper arch, especially my lower arch. And I felt my tongue actually relaxing more and getting out of being jammed up into the roof of my mouth and my airway. I see both of you nodding. You've evidently seen this more than once.
Yep. I'm actually, that's happened for me personally, by the way. My tongue doesn't fit in my mouth very well. So I know exactly what you're talking about. And I won't do it on screen, but if you ever want to check yourself, stick your tongue out in the mirror and look to see if you have little ridges along the edge of your tongue. If you have little ridges along the edge of your tongue, that usually means that your tongue doesn't fit in your mouth very well. So you're more likely to develop sleep apnea issues because your tongue gets in the way.
It does, and mine has. So I went on deeper in terms of I've always, because of the importance of this issue, I've worked on trying to find telemedicine access to sleep clinics. I did find one. I had treatment there, to see what it looked like, and it was a good treatment. It was. I'm blanking on the name of the company. They were out in California. They lasted for about 6 months. I was getting ready to start doing referrals into them because I thought it worked well, and they disappeared. So
I'm going to hop in here and tell you that one of the collaborators that we're working with is very much into telemedicine, and I saw that she's listening in, and there may be a way to hook that up again because she's working with a couple of nationwide telemedicine groups, and I really never asked her if they do telemedicine for sleep apnea, but her first name is Kathy, and you'll probably hear from her and see, how that's an important ingredient. And while, teledentistry is very difficult. Excuse me, open your mouth and stick it in front of the mirror. You can't do that. I got to physically get in there. But there are certain avenues that either with questionnaires and stuff, and the more aware that we can make the population, the lower the costs are going to be to people. And, we've all said this, that medicine and insurance companies are profitable because they provide care. They provide, they do things. They cut you, the surgeons, and they do this. This is a different direction, and it really has to come from the population because insurance companies want to make sure they get their VIG every year. It doesn't matter. And if they have more heart attacks, they get a bigger VIG. And I don't want to condemn them, but, for us to say, oh, you go get this test for your 5,000 employees or 250 employees, and you're self-funded rather than third-party, payers, your insurance rates are going to go down. So you as the employer is going to save money, and you're going to have people that are ready to be able to keep coming to work.
So the bottom line is it's sort of like preventive medicine, like primary care,
Right.
Very, very education oriented. There are some challenges in terms of telemedicine, but that's not the real challenge. The real challenge is awareness of the importance, and then understanding and education. Once you get past that, we're in a whole different ballgame. So, Bobby Ocampo, presentation of Ben Bickman on insulin to glucagon ratio. This is the second, maybe the third reference that I've seen to that. I don't really have a comment on that. I'm assuming neither of you do as well.
No.
But I will show you that, yes, Dennis Williamson and Bobby, very interested in that topic. Anyway, welcome to you guys. Let's get to the next question. Can prolonged days of water fast help with gums problems and therefore prevent stroke? Any trial on prolonged fasting and how many days to have reversal of at least soft plaque? I'm gonna toss that up to you first.
Well, I'm going to talk a little bit about that. And we talked about, if we go back to the science, bacteria can multiply every 20 minutes. And when you take any fermentable carbohydrates through your mouth, if you have that biomass, that goop around your teeth, it absorbs it like a sponge and could take up to 20 minutes to digest. So I don't know much about what he's asking, but if you don't feed them, their growth is stunted. However, that doesn't mean that the damage that's going on is stopping. I come back to stuff for all those years ago from Dr. G.V. Black. If you take off 75 to 80% of that goop circumferentially once a day, it becomes a moot point.
So I'll just make the comment that, Bobby, the literature, the science is full of discussions about different types of fasting, If you go back to the New England Journal coverage of intermittent fasting, gosh, I think I know it was December 26th. I remember it being the day after Christmas. It was a year or two before the COVID outbreak. So it was either 2018 or 2019. And they pointed out a very, very interesting thing. Number one, they pointed out that this is no longer just an internet phenomenon. The internet is grassroots. It's people noticing things, but it's not gotten through the research channels yet. They were making the point that fasting is not in that space anymore. There's clearly research that's going on, that has happened, that the evidence is really clear. The next thing that they demonstrated, though, was there's still confusion in the space about different types of fasting, and the two types of fasting and the confusion they pointed out were restriction, just caloric restriction. If you've heard that term, it's basically decreasing the number of calories on a day-to-day basis, as opposed to fasting one day and then eating the next, or intermittent fasting, which is eating at one or time restricted eating, instead of getting calories in over 16, 18 hours of the day, moving that down to a very short time period. What they pointed out was that a lot of the information which we thought was associated with caloric restriction was actually intermittent fasting. I'm not going to go into the details on why. The point that I'm going to make, though, is there's a lot of information out there. There's no question that fasting helps. There's also no question that minimizing body fat, maximizing muscle mass are critical. If you do those things alone are going to help minimize your chance of having a stroke. There's no question about that. So I can get way too deep and way too confusing in terms of details in the science. But again, there's no question. Minimize your body fat, maximize your muscle mass. You're going to minimize any risk that you have of stroke. So, Bobby, if 40 days water fast reverses cancer, any trials on 40 days? No, not that I'm aware of. Okay, let's go down. Lucian P. So what determines the stability of a plaque? I can take pine bark extract because I read a study which suggests that it can stabilize it. Well, you can take a lot of things. You can take apple cider vinegar. You can take bergamot. You can take a whole berberine. You can take a whole bunch of things. But the bottom line is anything that decreases the oxidative state, in other words, this pre-diabetic state, that will decrease the softness of your plaque. It'll decrease your risk for stroke. It will improve your health long term. So I started going through details. When I have a patient, our practice is different in that I actually show them their metabolic labs. So I let their body talk to them instead of them just hearing a doctor's interpretation. Their body doesn't lie. Their metabolism doesn't make stuff up. Their metabolism doesn't care about whether it's hurting their feelings. It doesn't care about whether it's scaring them or whether the discussion is pleasant or not. It just is. Now, when I'll go through something like fractionation, where it's clear that they've got a large HDL, and we'll start to describe, well, that's because you've got problems with your carb metabolism. We'll get into some of the technical stuff. You got problems with your carb metabolism. Fatty acids are replacing the cholesterol in those large, fluffy HDL. They're getting burned up as they pass through the liver. Their eyes glaze over. And then they say, okay, so how do I fix that? Well, it gets back to, you can try taking apple cider vinegar, and there's a place for that. You can try taking berberine. Yes, there's a place for that. Supplementation matters. But at the end of the day, you cannot out-supplement a diet. You cannot outrun a diet. You cannot out-prescribe a diet. You cannot out-bypass a diet. You cannot out-stent a diet. At the end of the day, lifestyle is king, and diet is the most important component of lifestyle. So diet is more than, exercise is important. High intensity intervals, very important. Resistance training is very important. We used to think it was all just aerobics. Well, aerobics are still important too, but they're actually not as important in terms of managing this oxidative lifestyle of prediabetes and diabetes as resistance training and high intensity interval training. Those may be important, but again, I'm going to repeat, you can't outlift, you cannot outrun a diet. Looks like we're not the only folks having some connection problems. Looks like we lost Phil.
I know. I was like, where'd he go?
Paul James, what causes a plaque to rupture? It's inflamed. It's soft. And Ari mentioned, Ari, didn't you use that analogy that they used when Tim Russert had his heart attack? He died. They did an autopsy, and they said the inside of his arteries looked like he had acne. It looked like the face of a teenager with acne. That's what we're talking about, Paul. We're talking about artery walls that look like the face of a teenager with acne. The pathologist for the Tim Russert case described that analogy very, very well. It's pus. It's inflammation. That white stuff is pus. JMK 2921. If your cardiologist orders a CIMT, make sure he knows what he's ordering. That's a good point. I asked my doc if the test would show soft plaque, and he said it would. My test did not differentiate soft versus hard plaque. JMK, you bring up a really good point. I'm finding from more and more people that more and more doctors have heard of me. I had a cousin of mine mention this to his doctor the other day, and he held his head and he said, "Oh yeah, I've heard of Dr. Brewer." Doctors are starting to get pinged a little bit, and their patients are starting to challenge and ask questions that are sometimes challenging. So they're starting to do some of these. Here's the problem. As Eric can tell you, Todd's quality assurance programs are world-class. I know of 3 CIMT groups that I would recommend using. I don't know of any other group. One of those groups just went out of business. So it's like there's not a lot of folks that are doing quality CIMT. So I don't know if you want to make any comment about that, Ari.
Yeah, it goes back to what you were saying, garbage in, garbage out. Todd's group over at CardioRisk has really rugged quality control. Each of his technicians to become certified, it's probably the scariest day of my life. It's done through double blind. Everything is all numbered. So you scan 5 patients twice, and your scans are compared against each other, which you're like, all right, whatever, as long as you know what you're doing, that shouldn't be a big deal. But the challenge then becomes is your scans are then compared to Todd's or an expert in the field, and you have to be less than 1% standard deviation off of not only your own scans, but the experts as well, in order to first even be qualified and certified by Dr. Todd. So that's hugely important because that means that no matter where you go in the country, as long as the technician is CardioRisk certified, you will get the same results within 1% standard deviation. And that's huge because you need to know if you're getting better, same, worse year over year. You can't be comparing apples and oranges. You can't, if the person is not looking in the proper protocol area, if the person isn't doing it correctly, if they're not thoroughly interrogating the artery, because it is a flat transducer looking at a round object. So if they're not looking, as many different places as possible, they may be missing soft plaque, because just from the physics of ultrasound, if you don't spin that dial, so to speak, and look all the way around, just from the physics of ultrasound, you're going to be potentially missing soft plaque. And since soft plaque is the most dangerous kind of plaque, and it's very hard to see, by the way, on an ultrasound. So if you're not thoroughly interrogating and looking everywhere and you miss that, you're potentially giving someone a false sense of security. And so all I can say to that is make sure you know who's doing your reads, make sure you know who your technician is, make sure they're actually qualified to do what they do. I won't say a name, but there's one that I'm sure that everybody's heard of that starts with the letter L, that travels around and does other tests as well, that says that they do heart attack and stroke prevention, and they don't. They actually do a flow study. And that makes me want to gnash my teeth together and beat my head into a wall, because they're sending folks out with a false sense of security. They're sending folks out thinking that they're healthy, and they may not be. They may be, but they may not be. So your body, your health, make sure that you know who your technician is and who they're certified through and who's doing your reads, to make sure that they're reputable, so that you get the right answers.
And I would add, quit worrying. I know that it's a great test. Everybody has this concept and loves arterial age.
Yeah,
I get it. I don't say never use it, but I would say focus on that, whether or not it's soft. That's what I keep trying to get folks to come back to. Do you have plaque? Number one. And is it soft? Number two. Keep it simple.
Yep.
So Peggy Douglas, recent wellness check. The PA would not order a CIMT since I was not having any symptoms like chest pain or other, quote, symptoms. I just have sky high LDL particles that's between A and B in size. So pardon my cough, by the way. I'm not going to go into my saga about that issue. Peggy, I'm sorry that your PA would not order the CIMT. I'm going to reiterate or repeat something that Ari mentioned earlier. You do not have to have a doctor's order. I've only heard of one place, and I think that was Oregon, where there was some question about whether they wanted to have a doctor's order. So number one, you don't need to have a doctor's order. Number two, Rafi, if you'll show our telephone number, Peggy will get you an order if you need one. And number three, Peggy, just go ahead thinking about getting a calcium score. So maybe we can help you out a little bit more. Let me give you one other comment. I get people all the time, especially since keto diet has become so popular, or low carb diet has become so popular. There's a phenomenon that's known that it's not just internet docs talking about it. It's not just some of the purveyors of standard medical research, like Harvard, have talked about. Sometimes if they go low carb, their LDL will shoot way up. You might be what's called a lean mass hyperresponder. Again, keep that number up, Rafi, because as you might guess, I get tons and tons of people that have these unusual things that most doctors have not seen. LP(a), for example, it's not unusual to us. Lean mass hyperresponder, not unusual to us. We actually had Matt Feldman on and had a little bit of debate with him about what is lean mass hyperresponder. Is there any overlap between that and another? Thank you for your patience with my coughing. Is there any overlap between Matt Feldman's lean mass hyperresponder and something else that most doctors are not aware of? FH, familial hypercholesterolemia. I see all these kind of things all day, every day, because if you're going to go on the internet and talk about them, you better be ready to see them and help. And I've had a blast working with these folks. We've got Joanna Farrell coming up in just a second with a few questions. Bobby's got some statements from The Philippines, top 4 causes of death. And I think this is a very important comment. Thank you, Bobby. This is not unusual. I don't know if it's which other countries, if any, in the world are different on this issue. Top 4 causes of death: heart disease, stroke, cancer, and diabetes. Now, guess what? Which of the 3 is not mostly due to insulin resistance? I mean, which of the 4? Cancer. And cancer is actually multiple diseases. There are some cancers that are at higher risk associated with prediabetes. But heart disease, stroke, and diabetes, all insulin resistance, prediabetes, diabetes. If we can just, here's the thing. It's crystal clear. Talk about awareness. It's crystal clear that we can take 95% of the risk for death and disability for those 3 diseases off the table. People just have to understand it. Thank you so much, Bobby, for sharing that. John Farrell, true, I suffered 2 strokes in 21 while in the hospital. I had double vision in my left eye for a week. Upon testing, they discovered I had 5 clots, which I passed successfully. Well, thank you so much, Jonna, for sharing your story. With the exception of one that broke off in my brain and caused the double vision in my eye. Sorry to hear that. Is it an expensive test? I think you're probably referring to CIMT, and most groups, I don't know if you want to share with your side, but I'll just make the generic comments. Most groups are between $200 and $500. Most of them are on the lower end of that range. Any comments, Ari?
Yeah, that's about right. It all depends on where you are in the country. Some physicians charge an extra rate on top of like what the CIMT charges, for their interpretation, visits type of thing, which, doctors deserve to make money too. But yeah, no, it's not an expensive test at all. I live in Martha's Vineyard, which is a stupidly expensive place to live. So mine is actually still at the lower end of the scale. I charge $250 for a scan. And I equate that for folks living on Martha's Vineyard. It's one dinner out. Food out here is expensive. Restaurants are expensive. Martha's Vineyard is expensive. So, it's a dinner for 2 out. So is your health and your wellness worth skipping a dinner for 2 out? I'd say so.
I think that's a great analogy, Ari. Thank you for bringing it up. So we'll go back to Jana's stroke story. Now I've completely recovered with a change in diet by going carnivore. We're now in my 9th month and dropped 100 pounds. So, Ari, I know because of your work with Todd and your work with Phil, you're very familiar with the Bale-Deneen community. I learned a lot of information from the Bale-Deneen community as well. A lot of neat stuff. They're doing the Lord's work. But Bale-Deneen doctors just give me the hairy eyeball and can't believe it when I say I have a lot of patients on a carnivore diet. It's not something that I routinely recommend, but I don't have a problem with it. I don't use it myself. What happens with me and a lot of other patients is if you eat a lot of red meat, it's hard to keep your weight down. But a lot of people do better keeping their weight down with carnivore. The typical Bale-Deneen recommendation is usually the Mediterranean diet. Mm-hmm. And if you've read the book, The Big Fat Surprise by Nina Teicholz, you'll understand the Mediterranean diet has a major set of challenges. Number one, especially for those of us who have risk because of prediabetes and diabetes, that's 90% of us. The Mediterranean diet can be full of grains, the number one source of carbs for most diets throughout the world. It can have grapes, it can have grape juice, it can have other fruits, and you just have to be careful with the carbs in the Mediterranean diet. Any comments about that disconnect between me and the Bale-Deneen community and the Mediterranean diet?
I just will say, everybody's body responds differently. Everybody has their own metabolism. Everybody, like you were saying, your body doesn't lie. And so what works for me may not work for you, which may not work for, Billy Smith over on, 2 streets over. So I think you're banging the head, the nail right on the head. Your body doesn't lie. If you don't feel well, you're probably not eating well for your body. And if you pay attention to that, that's actually one of the things that I talk to all my patients about. Is they often ask me, well, what causes inflammation? And one of the big bogeys is food. And people don't always realize that when you eat something that makes your stomach upset, it's doing more than just causing an upset tummy. It's causing more than just a GI issue. It's probably causing systemic inflammation. So if you tuck it in the back of your mind that you're like, gosh, every time I eat, insert food here, I just don't feel well. Well, don't eat that anymore, silly, because it's doing more than making you not feel well. It's probably causing systemic inflammation. And so I sort of am living proof of pay attention to what your body's telling you. Pay attention to when you eat something or drink something, and it makes you not feel well. Don't do that anymore. So to answer your question about, getting the hairy eye from the Baldinine guys, everybody's body is different and you have to find what works for you. And we can't always focus on this cookie cutter narrow lane, that's why some of these fad diets drive me cuckoo, because they're cookie cutter and everybody's body is different. Everybody's metabolism is different. Everybody's physical how physical you are during the day, what you do, everybody's different. So you've got to tailor it for you. That's my theory anyway. And poor Dad is texting me, by the way. So forgive me for looking off to the side of the screen. My dad's trying desperately to sign back in.
What's he texting? He's having some Wi-Fi problems as well.
Yeah, he's trying to sign back in and I guess he won't let him. So I said, try again. I don't know.
Okay. Well, tell him we said thank you. I'm going to have to wrap up within about 4 minutes anyway.
Okay.
The viewership has gotten big enough to where we just cannot answer all the questions anymore. So folks have to get their questions in soon, early, if they're going to get them answered, and they now know it. Jonna finished up with a critical piece. She dropped 100 pounds.
Wow. That's it right there. Big
deal. ET, thank you, ET. And basically what he's saying is, hey guys, it doesn't cost anything. It's not even doesn't cost a $5 or $10 or $20 super chat. Just hit the like button. It still helps to show the AI, the artificial intelligence, that this is worthwhile information. John Farrell, they tried to do an MRI of the brain, but I freaked out with a panic attack and it was not completed. John is bringing up a point, and actually, oh gosh, somebody asked, Bobby asked a few minutes ago, is MRI the best way or is it appropriate for screening for stroke risk? And the answer is no. CT is not a great screen either. None of those are screens for stroke risk. And it gets back to the reason of why. What causes stroke risk? And it's not so much something going on in the brain, it's something going on in the arteries. So I'll go back to, we've been talking today about one of the very best ways to screen for stroke risk, and that's the CIMT. Now, what John is talking about is an MRI after the fact. So what's called a non-contrast CT is the most common way of evaluating somebody when they come into the hospital and the stroke has already happened. Jonna can tell you, finding out what's going on and assessing the damage and trying to heal it after the stroke has already happened is not the way to go. The way to go is to prevent it. So get your CIMT, get your calcium score. Most of all, get an OGTT. Get a fractionated, a lipid fractionation study. Start from somebody who knows how to interpret it. Start figuring out what is your risk. Take your shirt off and jump up and down in front of a mirror and see how much bouncing you're having. Do the jiggle test. If you're having bouncing anywhere on your body, you've got some tissue in your body that's driving this process. And overall, yes, the obesity epidemic is driving the heart attack, stroke, diabetes epidemic, but not nearly as much as aging. So here's the thing. If you're over 40, clearly if you're over 50, start taking this risk seriously. Get a CIMT, get a calcium score. Start thinking about, well, how much risk do I have? Because the probabilities, Jesus and I talked about it last week. The probability is is 80% or higher that you have diabetes or significant prediabetes, enough to cause heart attack and stroke. Once you realize that you have that, once you find the root cause, which is usually going to be that problem, then the issue is, how can you take that risk off the table? And 95% of it you can take off the table. So this really is a curable problem, a curable risk. Take it seriously. Anything else before we go? From your side, Eric?
No,
Eric?
I'm good. I think that was great. Get your CIMT, take care of yourself, pay attention to what your body's telling you. Be your own health advocate, because we want to keep you being as healthy as you are alive. We want your health expectancy to equal your life expectancy. We don't want everybody around in a vegetative state, or, having someone have to change your diapers. No, thank you. We want to keep you guys healthy. And this is an easy, painless way to do that. Non-invasive. Take good care of your teeth, take good care of your gums, and listen to your body. Listen to your doctor too, but listen to your body.
Very good. Sometimes I would much rather them listen to their body than their doctor. Thank you so much, Ari.
Thanks for the invite. I appreciate it.
Bye-bye.
Everybody stay well.